So, okay, good evening, everyone. I hope I am audible and visible to everyone. Okay, just tell me hello, hi, whatever. Am I audible and visible? Yes, namaste, Yuvraj. Good evening. So, please, everyone, join fast so we can start the discussion of important topics with the help of few MCQ. So, am I audible? Sorry for my bad throat. Okay, good. Abhishek Kumar Pandey, good afternoon, good evening. Okay, so without further ado, let me start with the question number 1. Actually, these are few questions of the previous year FMG paper, but the purpose is not only to solve MCQ, because of course they will not be repeated. They are not going to repeat your MCQ, but of course in every examination, in MBBS, in FMG, every examination, topics are very important. Same topic they keep on repeating every year, either in the form of clinical question or applied question or integrated, whatever, but these topics are very important. Okay, Vishnu? So, first question is that insulin stimulates glucose uptake by cell via GLUT4. This is an example of primary active transport, secondary active transport, simple diffusion, or facilitated diffusion. What is your correct answer? Yes, please answer. GLUT4, it is a primary active, secondary active, simple diffusion, or facilitated diffusion. Yeah, Deep Susa, you are correct, absolutely correct. All GLUT are facilitated diffusion. Very good, absolutely correct. Your answer is no. Try to understand this topic. This topic is important. Every year, one question is definitely from glucose transport. Okay, now let me discuss this topic, glucose transport. What do you know about glucose transport? This topic as such is very important. One or even two questions are only from this topic. This can be of two types. Number one, it can be either secondary active transport, and second is facilitated diffusion, or you can say passive. The example of passive here is facilitated diffusion. In secondary active transport, what are the example? SGLT1 and SGLT2. Now these, among all these two, okay, which is present in the kidney, 1 or 2? Among this SGLT1 and 2, which is present in the kidney? Both are present in the kidney. Both are present in the kidney. On which side? Luminal side or basolateral side? If this is your one cell of the kidney, they are present on the luminal side or on the basolateral side. Whatever I am asking, these all are your MCQ. They are present on the luminal side. Very good, excellent. They are present on the luminal side, not on the basolateral side. And SGLT1 is responsible for only 10% of transport. SGLT2 is responsible for 90% of glucose absorption in the kidney. 90% by SGLT2, only 10% by 1. But in the intestine, which is present? In your intestine you have only one, and that is SGLT1. इंटेस्टाइन में सिर्फ एक होता है SGLT1, but in the kidney you have SGLT1 as well as 2. Very good. That is why in diabetes mellitus, which drug you give? SGLT1 blocker or 2 blocker? Of course SGLT. Which one? Of course you will give SGLT2 blocker. So what are the drugs that are SGLT2 blocker, doctor? What are the drugs that are SGLT2 blocker? Anyone? Of course, if you block SGLT2, glucose will not be absorbed. Answer is canagliflozin. What is the answer? Answer is canagliflozin, dapagliflozin, empagliflozin. There are so many, and all end with gliflozin. These are SGLT2 blocker, not one blocker but 2 blocker. And the side effect of these drug will be what? Urinary tract infection. Sorry, why UTI? Because glucose is coming in the urine, so there are chances of development of UTIs. Very good. Now other type of transporter is which one? Other type of transporter is which one? Please tell me. Glut. Now, what are the questions which are asked regarding glut? Anyone? Glucose transporter. Glucose transporter 1 is located where? It is located in the blood-brain barrier, number 1. Number 2 in RBC. Yes, very good, understand. Number 2 is RBC. Number 3 is placenta. The location of GLUT1 is blood-brain barrier, RBC and placenta. Location of GLUT2. Where is the location of GLUT2? The mnemonic is beta cell like. Simple mnemonic, beta cell like. Beta means pancreas. GLUT2 is present in the pancreas beta cell. L stand for liver. It is in the liver. I stand for intestine. I stand for intestine, and K stand for kidney. K stand for kidney. Very good. So this is GLUT2. What about GLUT4? What is the important point regarding GLUT4? It is the only GLUT that is insulin dependent. It is the only GLUT. Very good, excellent. Insulin dependent. And this is present where? This is present in the skeletal muscle as well as your adipose tissue. Adipose tissue. What about GLUT5? F for 5 and F for fructose. It is not for glucose, it is mainly for fructose. Am I clear? So GLUT, all GLUT are example of facilitated diffusion, which is a type of passive transport. Okay, good. Next question, again a very important question. Believe me, every year you will get 3 to 4 question only on pH. It can be from physiology, you can say, or medicine, but concept is same. Regarding pH, 3 to 4 questions are for sure. So let us discuss that topic. This is a very simple question, last year FMGE question. ABG of patient shows pH of 7.23, carbon dioxide 60 mmHg, PO2 at 2 mmHg, 80 mmHg, bicarbonate 26 mmHg. What is the diagnosis? So this is a very simple question, but we will discuss. Namaste Kajal Maurya. Namaskar. Okay, tell me the answer. This question is very easy, damn easy. But what should be the approach of this question? So everyone is saying A. Very good. Respiratory acidosis. pH. So what should be the approach of this case? Whenever you get any clinical MCQ or case-based scenario in any examination, first see the pH. Okay. Second, you have to see carbon dioxide, and third, you have to see bicarbonate. These 3 points you have to see in the question. Okay. The normal pH is how much? It is 7.35 to 7.4. Carbon dioxide you can say around 40 and bicarbonate 24 to 28. Please remember these values. These are the normal value. Okay. In this particular question, pH is less. So of course it is acidosis. Then see carbon dioxide. It should be how much? 40. And it is how much? 60. It is more or less? More. So respiratory acidosis or respiratory alkalosis. What is the answer? Namaste movie manic. What is the answer? Answer should be respiratory acidosis. Respiratory acidosis. But bicarbonate is approximately normal, so there is no compensation. The only answer correct is respiratory acidosis. But normally they will not ask you that simple question. Let me tilt this question in some other form. Suppose in the patient pH is 7.8. Good evening, Deepika. Carbon dioxide is suppose 60. Bicarbonate is suppose, let me assume as 30. Now what is your diagnosis? Please everyone write. I want comment with everyone. Now what is the answer? pH is 7.8, carbon dioxide is 60 and bicarbonate is 30. What is the answer of this question? Yes, awesome. Blossom. Carbon dioxide is higher, so respiratory, okay. What respiratory? Acidosis, alkalosis. What is the answer? Please, you have 30 seconds, everyone. There are 60 live students. I can see. I want answer from everyone. How many are seeing respiratory alkalosis? Okay. Metabolic compensation. Please, this question is a must for every MBBS, PG, FMG, every examination. They are going to ask you. Yashvardhan single metabolic alkalosis with compensatory respiratory acidosis. Faizi Murtaja metabolic alkalosis. Namaste Manish. Respiratory. So lot of correct answers are coming here. Very good. Excellent. Lot of correct answers are coming. So what you have to see? Yes. First you have to see the pH. pH is normally how much? 7.35. And it is 7.8. So diagnosis is clear. Alkalosis. It is clear. Alkalosis. CO2 should be 40. It is 60. So what is this? Acidosis or alkalosis? Acidosis. So respiratory acidosis. Bicarbonate should be 24. The base is 24. And this is 30. So it is more. So alkalosis is there. So metabolic alkalosis. So your pH is correlating with what? Respiratory or metabolic? With what your pH is correlating? Answer is metabolic because it is alkalosis. So the final answer is metabolic alkalosis with, although it is partial, but we can write compensatory respiratory what? Acidosis. Am I clear? So like this, the approach should be to see the pH, number 1. Number 2, carbon dioxide. And number 3, bicarbonate. But one more question. One more example I will ask you. Tell me now, suppose in the question pH is, suppose in one question you get pH as 6.8, carbon dioxide as suppose 20, bicarbonate suppose is 12. What is the answer? You have only 15 seconds. What is the correct answer, doctor? Yes, be fast. Only 15 seconds you are having. Metabolic. Please write the full answer, not half. Never say half answer. Always come with along with the compensatory and everything. Metabolic acidosis with compensatory. Parasgen metabolic. Yes, parasgen metabolic acidosis only. No compensation. So a lot of correct answers. So I think this concept is absolutely clear to everyone. Very good. So pH is 6.8. So it is what? The final diagnosis is what? Acidosis. Carbon dioxide should be 40, but it is 20. It is alkalosis. So respiratory alkalosis, it is opposite. You can see here. Bicarbonate base would be 24, but it is only 12. Base is less. So metabolic acidosis. Metabolic acidosis. So which is correlating with this? Of course, metabolic. So metabolic acidosis with compensatory respiratory alkalosis. Wonderful. Maximum of you are correct. You got the point. Good. Next question. Very simple question. Pancreatic cell tumor leading to secretory diarrhea is VIPoma, glucagonoma, insulinoma, Zollinger-Ellison syndrome. What is the correct answer? Yes, please tell me. Pancreatic cell tumor leading to secretory diarrhea. Very simple, often repeated question. Everyone know about this. Recurrent secretory diarrhea, hypokalemia. These symptoms are common in which disease? Yes, very good. VIPoma. Very good. VIPoma. You know everyone. This is a simple question. Insulinoma. If you have more of insulin, there will be recurrent episode of hypoglycemia. Okay. In Zollinger-Ellison syndrome, you have intractable peptic ulcer. Okay, this is a simple question. I can move. Now, this topic is very important. Of all the following, which is not an attachment protein, believe me, every year you are going to get one question from muscle protein. One or two questions. Let me discuss that topic. First, tell me the answer, then I will tell you. Among all this, which is the only that is not attachment protein? Yes, Ashish Nayak, very good. Vada syndrome. Very commonly asked question, important topic. Yes, tell me. Titin, desmin, nebulin or tropomyosin? Fast. Desmin Parth, which is not an attachment protein. Desmin, tropomyosin. Yes, deep. B. Desmin. Okay. Okay. Very good. So let me discuss this topic. How many proteins are there in the muscle? How many proteins are there in the muscle? There are 3 proteins. Number 1 is called as, tell me, contractile protein. Yes, tropomyosin is, very good Ashish, you are correct. Contractile protein, then you have regulatory protein, and then you have there are lot of structural protein. Lot of structural protein. But only 2 contractile protein everyone knows. One is actin and other is myosin. Please don't forget, actin and myosin are 2 contractile protein. Regulatory are only 2. What are those? Troponin and tropomyosin. Tropomyosin is a regulatory protein. Please remember. This is a very important topic. Please listen very carefully. Structural are so many, like titin, nebulin. Okay. Then you have dystrophin, myomycin. There are so many protein. You have alpha actinin. Okay, you have myomycin, nebulin. All these are structural protein. What to remember in the exam? Actin are of two type. If actin is monomer, it is called as G-actin, globus actin. If actin is polymer, what is this called as far as? You know about G and F. F-actin. Okay. So monomer is G-actin and polymer is F-actin. It is GF. G matlab monomer, F matlab polymer. It is about actin. Now what about myosin? What about myosin? Yes, tell me. Myosin is a hexamer protein. Myosin is a hexamer protein. Okay, it has two myosin heavy chain, two myosin light chain, and two myosin regulatory chain. Okay, now see this. This is your beautiful myosin heavy chain. This is called as head of myosin. This is called as neck of myosin. This is called as tail of myosin. हाँ भाई अनिल जुकाम लग गया. Okay, this is head of myosin, neck and tail. Okay, now they will ask you on the myosin at what part ATPs are attached. ATP किससे अटैच होती है? हेड, नेक और टेल. आंसर इज हेड. नंबर 2, which part of myosin has actin binding segment? Again answer is head. Head has actin binding segment. Okay, so head of the myosin has ATP binding segment as well as actin binding segment. Now I have told you that this is what? G-actin or F-actin? What is this called as? This is filamentous polymer actin, so this will be F-actin, isn't it? And what is this? What is this called as? This is called as tropomyosin. Again, question of your FMG. Tropomyosin is a contractile protein or a relaxing protein? Tropomyosin is a contractile protein or a relaxing protein? Answer is, doctors, they are relaxing protein. Why? Why they are relaxing protein? Because tropomyosin cover what? Myosin binding site on the actin filament. They cover myosin binding site on actin filament. So they are not allowing actin myosin to bind. They want to bind always. And who is breaking this? It is your tropomyosin. Tropomyosin is wrapping around like a DNA helical structure which is wrapping around the actin and preventing the binding. So it is a contractile protein or a relaxing protein? It is a relaxing protein. Now you have one more protein called as troponin C. You have one more protein called as troponin. Troponin have 3 subunits. One is troponin T, troponin I and troponin C. Troponin T binds with tropomyosin. Very very easy. T with T. Troponin किससे बाइंड करता है? Yes. And troponin I, troponin I inhibit actin myosin binding. Troponin I क्या करता है? Inhibit करता है. And troponin C, C stand for what? Calcium. Only when calcium come, it will cause conformational change to uncover actin myosin site and contraction will happen. Is this clear? So only when calcium come, troponin C bind with the calcium, cause conformational change so that actin myosin can bind together, causing contraction. So this is called as light chain. Your again MCQ. Which is light chain? Heavy chain and light chain. Light chain means you have actin, you have tropomyosin, and you have troponin. These together constitute light chain by these components. Okay, so of course you have to have detailed knowledge of this protein. Next question, again very important. Which of the following is correct about ROMK channel? Which of the following is correct about ROMK channel? Uniport, symport, antiport, or all of the above? Uniport, symport, antiport, or all of the above? Which is correct regarding ROMK? Renal outer medullary potassium channel. Very famous channel in the kidney. Uniport, symport, antiport, all of the above. Yes, Jayant, Parth, Harshit, A. Okay, very good. Very good, excellent. Maximum of you are correct. So, do you remember the location where we have discussed this? हमने कहाँ पर पढ़ाया था ये? कोई बता सकता है हमको? Anyone can tell me where we have discussed this point? ROMK? Where they are present? Of course, there's a lot of places, but do you remember about TAL? Thick ascending loop of Henle? Yes or no? In thick ascending loop of Henle, yes, you lost remember type 2 Bartter syndrome. Very good. On the basolateral membrane, you have a sodium potassium pump. Very good. Bartter syndrome. Very good. Excellent. This is thick ascending loop of Henle. Very good. And this is which channel? Which channel is this one? Tell me. NCC or NKCC? It is NKCC. Sodium potassium 2 chloride channel. NKCC. Sodium will be taken by this. Chloride will be taken by this. But ROMK will put this potassium back in the lumen. Please remember, these are ROMK. These are uniport. This is symport. This is again symport, but this is uniport. Do you remember this? And what was the location? Location was thick ascending loop of Henle. Thick ascending loop of Henle. And all of you very well know that if there is mutation of NKCC, it causes which syndrome? Bartter syndrome. Very good. Everyone has correct answer. Bartter syndrome. But in the pharma, if they ask you which drug is going to block this NKCC, then what will be your correct answer? Which drug is going to block your NKCC? Answer is loop diuretic. Loop diuretic. Like for example, furosemide, torsemide, ethacranic acid, all these loop diuretic are working on NKCC channel. Am I clear? Very good. So this was about TAL. Now coming to the next question. Comment on the hormone produced by the marked cell. Which hormone is produced by the marked cell? I will try to take class as crisp as possible. I will not, because your time is very crucial. One more class is there after you that. So I will try to concise everything. So be fast. At least I want to cover those important topics that can come this year in the examination. Which hormone is this? Yes, marked cell is this one, not follicular, but clear cell. So answer is calcitonin, not parathyroid, not thyroid. Okay, see, C cell form calcitonin. Why they are called as C cell? Follicular cell form thyroid hormone, and parafollicular cell form what? Calcitonin, because they have C cell. What is full form of C? C is not calcitonin. It is not chief. It is called as clear cell. They don't stain, so they are called as clear cell. Clear cell. Calcitonin. Calcitonin decreases blood calcium level. Okay. So remember, follicular cell produce thyroid hormone and parafollicular produce calcitonin. Next question. Left shift of the oxygen dissociation curve is seen in. From NEET UG times, they keep on asking left shift, right shift. So please don't make mistake in this question. Increase in temperature, increase in 2,3 dpg, increase pH or increase PCO2. What is the correct answer? This is oxygen hemoglobin dissociation curve. First question will be why it is sigmoid. You can see in this diagram why it is sigmoid. And second question will be what causes right shift, what causes left shift. Very good, excellent. Almost all of you are correct. Very good. So answer is C. Now let me discuss this topic. Question number 1. Why oxygen hemoglobin dissociation curve is sigmoid in nature? What is the answer? Answer is due to cooperative binding. Answer is due to cooperative binding. What is cooperative binding? What is cooperative binding? See, hemoglobin has how many pockets? Hemoglobin has 4 pockets. If one oxygen come, it will bring one more oxygen, it will bring third oxygen, it will bring fourth oxygen. But if one oxygen goes, second will go, third will go, and fourth will also go. It is called as cooperative binding. All remain in cooperation. Either all will be there or all will be gone. Am I clear? It is called as cooperative binding. So if they ask you in the examination in your FMGE paper, what is the cause of sigmoid curve? Answer will be cooperative binding. And if they ask you what is cooperative binding, you say one oxygen molecule attracts second, second attract third, third attract fourth. Like this, they keep on cooperative binding. Okay. Second question. There are 2 types of shift. One is called as right shift, and other is called as left shift of oxygen hemoglobin dissociation curve. Always remember, right shift means what? Whenever you need more oxygen, shift will be right. When you need less oxygen, shift will be left. So when need is more, when oxygen is needed, so it means dissociation is more or less. Dissociation is more. Affinity is more or less. Affinity become less. So what are the condition when dissociation become more and affinity become less? And answer are, of course, whenever you need, like for example, acidosis. Very simple. Okay. Like decreased pH, increased carbon dioxide. So all causes of acidosis, decreased pH, increased carbon dioxide. Or even if you're exercising, if you exercise, you need more oxygen. So whenever you exercise, you need more oxygen. So shift will be right. Or if there is more 2,3 dpg, shift will be right. And what is the condition of left shift? So whenever you need less oxygen, like pH become more, like alkalosis, like alkalosis. pH is more means alkalosis. Or fetal hemoglobin. Fetal hemoglobin. Because they want to snatch oxygen from mother. That is why they will have more affinity and less dissociation. So please do remember the cause of right shift as well as left shift. Next question, very famous question. Gower sign has been demonstrated in a child in your OPD. Okay, workup shows decrease or altered dystrophin protein. Diagnosis is DMD, BMD, congenital myopathy, or what? Gower sign is very, very characteristic of which disease? which is the most common cause of Gower sign. Anyone? DMD, okay. Parajan, DMD, Harshit A. Very good. See, what is the function of dystrophin? Dystrophin is like an anchor of the ship. Your skeletal muscles are held together with the protein called as dystrophin. Very good. So your skeletal muscles are held together by the protein called as dystrophin. See, what is the purpose of contraction? To make the movement. Why biceps contract? To make your movement. Why your leg contract? So that you can walk. So purpose of dystrophin is to transfer skeletal muscle contraction to the bone. And if there is a mutation of dystrophin, it causes mainly DMD, Duchenne muscular dystrophy. It is characterized by two very important things. One is called as Gower sign, in which if you ask the patient to stand while sitting, so he will walk on his own limb. It is called as Gower sign. And second very important characteristic is pseudo hypertrophy of the calf. Pseudo hypertrophy of which muscle? Calf muscle. Because now contraction can happen, but it cannot be transported to the muscle, skeletal bone, this bone. So he cannot walk, he cannot stand up from the sitting position. So these two are very, very characteristic of Duchenne muscular dystrophy. Yes, Dr. Cole, in December 2023, FMGE or next, most probably they are saying next. Even if there is FMGE, the pattern is completely next pattern. For last 2-3 years, you can see all questions are clinical. So of course, when they ask you physiology or anatomy, they will integrate everything and they ask. So please try to prepare from next pattern only. When ORS is given to the patient, glucose is absorbed by. Very simple question, same question I've told you. One question will be definitely from glucose absorption. So when you give ORS, ORS has glucose also, sodium also. So by which transport? It is transporting simple diffusion, osmosis, facilitative or secondary active. Yes, Tawfiq, you are correct. In Baker's also there it can be positive. You are correct. But if there is mutation completely, it is always Duchenne muscular dystrophy. Baker's muscular dystrophy is a mild variant, but Duchenne muscular dystrophy is a severe variant. And they usually die because of what? Respiratory palsy. In Duchenne muscular dystrophy, they usually die by 18-19-year-old. I've seen so many cases that they usually die because of respiratory palsy. So everyone is correct now this time, because we have discussed earlier also that whenever glucose is absorbed in intestine, it is by SGLT 1 or 2. Of course 1. SGLT 1 is what? Secondary active transport. Answer is D. Very good. Most of you are correct. Now this is an image based question. Of course you know this. There are 4 areas on the precordium. Okay. So arrange the following in the right order. If you see the diagram, you have to tell me which is the first area, second area, third area, fourth area. It should be at the tip of your tongue from MBA first year itself. Yes, Deep, you are correct. ORS is SGLT. What is the correct answer? Amitesh. The first is which area, second is which area, third is which area, fourth is which area. Which area is this? On the right side, upward. Tawfiq Rahman, yes, very good. This is the first area. I must write it on this. First area, second area, third area, and fourth area. Now tell me, aortic, pulmonary, tricuspid, or mitral, pulmonary, aortic. What is the correct answer? Very good, Yuvraj, very good, Uvesh Salam. So this is, of course, very good. So this is the aortic area, pulmonary area, tricuspid area, and mitral area. It is a common Viva question also, na? दे कीप ऑन आस्किंग, पूछते रहते हैं भैया एरिया बताओ पहले. फर्स्ट क्वेश्चन इज व्हाट इज द एरिया. ओके, व्हाट इज द एपेक्स बीट? What is the apex beat? It is the downward and the lateral most area of definite cardiac impulse. It is not always say this is from fifth intercostal space, this is the location. No, it is the downward lateral most area of definite cardiac impulse. It is called as apex beat. Don't say it is on the fifth intercostal. It is normally, but this is not a definition of apex beat. Okay. A female complain of cramp in the breast while breastfeeding. Which hormone is responsible? A female is complaining of cramp in the breast while breastfeeding. So which hormone is prolactin, oxytocin, prostaglandin, or somatostatin? What is the answer? It is asking about ejection or secretion or ejection. Okay, I will not give you hint. You first of all tell me the answer, then I will tell you. Yes, very good. Faizi, Parth, Himanshu, very good. See, prolactin has 3 function. Oxytocin has 2 function. The prolactin का पहला function क्या है? Number 1, milk production. It is called as lactogenesis. Lactogenesis. Yes, very good. Number 2 function is mammogenesis. Increase size of the breast. Mammogenesis. Lactogenesis, milk production. Mammogenesis, increase size of the breast. And the third is, what is the third one? Anyone? Lactogenesis, mammogenesis. It also decreases ovulation. That is why lactating mother is like physiological contraceptive. On the other hand, oxytocin has mainly function of milk ejection. So you can see here in the question, milk ejection. And number 2 is what? Uterine contraction. And these both are example of which mechanism? Feed forward, feedback, positive feedback or negative feedback. These both are example of what? Feedback or feed forward, positive feedback or negative feedback. What is the correct answer? Very good. Positive feedback. Do you remember the mnemonic of positive feedback? We are given claps. C for clotting, L for lactation, A for action potential, P for parturition, S for shock. It is also LH surge. L for LH surge also and lactation also. So oxytocin, when baby starts suckling the nipple, it will start oxytocin. It will again start ejection. So it is a type of positive feedback. Absolutely correct. Very good. Next question. Hormone. Now this is not a question. This is a whole topic. Hormone that regulate serum calcium level. Hormone that regulate serum calcium levels. Calcitonin, parathormone, vitamin D3, all of these. Hormone that regulate serum calcium level, calcitonin, vitamin D, parathyroid hormone, or all of these. Yes, all of this. This is a topic. This is actually a topic. You know this. Very easy topic and very, very important. Damn important for your physio, pharma as well as medicine. The 3 hormone that regulate. One is your parathormone, second is vitamin D3, and third is calcitonin. Third is calcitonin. Parathormone causes what? Increases calcium but decreases phosphate. Please remember, this is very, very high yield triangle. Of course, okay, vitamin D3 not only increases calcium but also phosphate. But calcitonin always decreases calcium. Calcitonin calcium को कम करता है. Calcitonin always decreases the calcium. Calcitonin calcium को कम करता है. Parathormone increases the calcium, decreases the phosphate. Now, lot of things, lot of MCQ, at least you can solve 50 MCQ by this much of knowledge. How? If parathormone is increasing the calcium, it will dissolve the bone, yes. It will increase calcium from the kidney, yes. It will increase calcium from the GIT, yes. But it will not absorb phosphate because it has to decrease the phosphate. So what is the function of parathormone? If someone asks you parathormone function, you can write everything that increases blood calcium level. If someone asks about vitamin D3, it not only absorbs calcium but also phosphate. Okay? And about calcitonin, it always decreases calcium. So someone asks you what happened in hyperparathyroidism. So what is the answer? Calcium will be very high and phosphate will be very low. If someone asks you what happened in the rickets or osteomalacia, not only calcium will be low but also phosphate will be low. Very, very important point. पैराथॉर्मोन में चक्कर उल्टा ऊपर ऊपर नीचे का, एक ऊपर एक नीचे. One will be high, other will be low. In vitamin D3, either both will be high, like in hypervitaminosis, or both will be low, like in rickets and osteomalacia. Please don't forget, this is very, very high yield clinical point. And calcitonin has no role on phosphate, only on calcium. This is clear? Now, next question. Parathormone have receptor at the level of. Parathormone have receptor or the level of osteocyte, osteoblast or osteoclast. पैराथॉर्मोन का रिसेप्टर किस पे होता है? ऑस्टियोसाइट पे, ऑस्टियोब्लास्ट या ऑस्टियोक्लास्ट? On which cell of the bone parathormone receptors are present? Yes, Parth, you are correct. They are present on osteoblast. But I have told you they are going to dissolve the bone. So how it is possible? Osteoblast are bone forming cell, not dissolving cell. So how they are going to help in dissolving the bone? Because now they will find which ligand? Rank ligand. Now they will form a ligand called as rank ligand, which is going to activate which cell? Yes, very good. Osteoclast. Osteoclast. And these osteoclasts will dissolve your bone like anything. And calcium will increase. Am I clear? Yes, very good. So, receptor of parathormone is on osteoblast. It will form a ligand called as rank ligand, which is going to activate the cell called as osteoclast, that is going to increase your calcium. So, rank ligand is a good, it is a hero or a villain for the bone. ये बोन के लिए क्या है, हीरो है या विलन है? It is a villain. It is dissolving your bone. That is why every time you have a hormone that inhibit rank ligand, who will tell me the name of the hormone that is going to inhibit rank ligand? Very, very important question. Which hormone inhibit rank ligand? Which hormone going to inhibit rank ligand? Answer is very good. Some of you are saying OPG, osteoproteogenin. Osteoproteogenin. Please remember, this is very, very damn important. Why? Because OPG are stimulated by three hormone again. One is your growth hormone, other is your testosterone, and third is your estrogen. So rank ligand is a villain for the bone. It can dissolve your bone. That is why you need to inhibit this rank ligand by osteoproteogenin. And this OPG are stimulated by three important hormone. One is growth hormone, testosterone, and estrogen. That is why after menopause there is osteoporosis, because after menopause estrogen become less, OPG become less, rank ligand become more. It causes osteoporosis. So this is called as post menopausal osteoporosis. Are you getting my point or not? So whenever a patient come to your clinic or OPD who had her menopause, one drug should always be given. What is the drug of choice for post menopausal osteoporosis? Which is the drug of choice? Every year they ask this question in FMGE or NEET PG. Answer is bisphosphonate. Answer is bisphosphonates. Bisphosphonates are drug of choice for osteoporosis because they inhibit osteoclast. Bisphosphonates are going to inhibit osteoclast. Okay, so they are best drug of choice. Otherwise you can also give antibody against rank ligand like denosumab. It is monoclonal antibody against rank ligand. Now one year they ask which is the only drug given in osteoporosis that has dual effect, that increase osteoblast, decrease osteoclast. Which is that drug? The only drug that has dual effect, and answer was strontium ranolate. Strontium ranolate. So every year they keep on asking this question. Please try to mug up, remember for exam, and don't forget. So once again, question number 1. Receptor of parathormone is on osteoblast. How it act? By rank ligand. On which cell? Osteoclast. Okay. Which is the inhibitor of rank ligand? OPG. What is the hormone that stimulate OPG? Growth hormone, testosterone, estrogen. Okay. Badhiya. A monkey has... Yes, Parth, tell me the answer. A monkey has increased sexual activity, increased appetite, anger, and no fear. Injury to which structure is suspected? What is this syndrome called as? Yes, Tawfiq Rahman. You know, very famous syndrome. What was removed in monkeys that he become very, very hypersexual, libido increases, no fear, he start eating the snakes, hyperorality. Yes, I will give this PDF after the session, Nikhil. I will give in this Telegram group. I will share all this PDF for your revision purpose, of course. Very good, Hitanshi. Kluver-Bucy syndrome. This is called as Kluver-Bucy syndrome. And what was removed? Yes, doctor, tell me. Amygdala. Amygdala क्या होता है? मन. What is मन? Limbic cortex. मन is your limbic cortex. दिल का रास्ता कहाँ से आता है? पेट से नहीं जाता है, amygdala से जाता है. Amygdala is called as window of limbic cortex. Window of limbic cortex. So it is the window of your मन, your limbic cortex. You are not feeling good because of amygdala. Amygdala, through amygdala, everything is going to your limbic cortex. It is the window. And when you damage this amygdala, it is called as Kluwer-Bucy syndrome. Normally, it is not visible in human beings. Only there can be bilateral temporal cortex injury. Only then you can see. Otherwise, it was done in monkeys. They damage selectively the amygdala. And they notice that he has no fear. He pick up the snake and start eating. Number one. Number two, hyperorality. He want to put everything in the mouth. He want to put everything in the mouth. Hyperorality, hypersexuality, hyperphasia. No fear. Okay. So this is called as Kluwer-Bucy syndrome. Next question. Very, very again important topic. They are touching only those topics which are asked every year. The following graph represent handling of what by glomerulus? Display, filtration. No, this is very simple topic. I will discuss this topic because this is very important. But first tell me what is the answer? Urea, glucose, chloride or insulin? Shubham Parashar, where can I ask your doubts? Just join my Telegram group. Put any doubt, whatever you have, I will try to answer that. I will share my link, group link here. What is the answer? So this is very simple. Everyone know glucose. Everyone know glucose. But I want to discuss 3 points. Please remember 3 points. Number 1, doctor. Tell me. हाँ जी सर बताइए. Number 1, what is the filtered load of glucose? What is the filtered load of glucose? Number 1 question. Number 2, what is Tmax? Transport maximum. The maximum ability of glucose to get absorbed. And number 3 question is, what is renal threshold of glucose? What is renal threshold of glucose? Yes, tell me the answer. How much is the filtered load? कितना फिल्टर होता है 1 मिनट के अंदर? ग्लूकोज कितना फिल्टर होता है? हाउ मच ग्लूकोज इज फिल्टर्ड इन 1 मिनट? 350 नॉर्मली, नॉट इन डायबिटिक पर्सन. उसमें तो कितना भी हो जाएगा. नॉर्मली कितना होता है? दीज आर 3 क्वेश्चन प्लस 4th क्वेश्चन इज व्हाट इज डिस्प्ले. $200, 100, 300, 400. So what is the answer? Arshia Khan, absolutely correct. Very good. Well done. 100 milligram per minute. Absolutely correct answer. 100 milligram 1 मिनट में फिल्टर होता है. 100 milligram is filtered every minute. What is the transport maximum? How much can be reabsorbed? How much glucose can be reabsorbed from the nephron? The maximum capacity of SGLT is called as, again correct answer is by Arshia only, 375 milligram per minute. Absolutely correct answer. एकदम सही आंसर है. 100 milligram फिल्टर हो रहा भाई, and 375 you can reabsorb. Only 100 is filter. Can glucose come in urine? Yes or no? Yes or no? No. But 100 is coming normally, and your capacity to reabsorb is how much? 375. So normally no glucose come in urine, but in diabetic patient glucose keep on increasing. A time will come when glucose start coming in urine. What is that blood glucose level called as? That is called as renal threshold of glucose. And what is the value of this? What is the value? Please remember, it should be at the tip of your tongue. You should never forget. If you want to clear your FMG examination, you should never forget this answer. Because these are every year asking. They are asking every year, na? So how can you afford to lose this question? What is the renal threshold of glucose? Sahil Ojha, absolutely correct. Wonderful. Aditi Gupta, parsing, very good. Parsing 180 milligram what? Per deciliter. Faizi Murtuja, very good. 180 milligram per deciliter. Absolutely correct answer. Till 180 to 200 milligram per deciliter, glucose never come in the urine. Only after that, glucose start coming in the urine. Okay. So what is splay? Splay is actual renal threshold is 180, but calculated is 300 milligram per deciliter. So there's a difference in the actual and the calculated, and this difference is called as splay. Actually, it is how much? Actually, it is 180, but it should be how much? 300. This difference is called as splay. Yes, Paras, you are correct. And what is the cause of splay? Cause of splay is heterogeneity of the nephron. All nephrons are different. Some leak early, some leak late. This is the reason for splay. So this was topic regarding in gestational life, surfactant are produced by which cell? Surfactants are produced by which cell? Type 1 or type 2 basal cell? No, this is a very easy question. You know this. Surfactant are produced by which cell? Very simple question, everyone knows. Yes, type 2 pneumocyte, you know this. And they are produced in the form of which body? Surfactant are produced in the form of course, by type 2 pneumocyte. And what are these bodies called as? Lamellar bodies. What are these called as? Lamellar. I'm really very sorry for my bad throat. Please don't mind. This class was already, time was decided, so I cannot change that. Yes, very good. Lamellar bodies, and they are secreted. They are secreted by in the form of tubular myelin. Tubular myelin. They are stored in the form of lamellar body. They are dense, compact lamellar bodies, and they are decorated in the innermost layer of alveoli by which protein? Surfactant protein B and C. Okay. So they are stored in the form of lamellar bodies, they are secreted in the form of tubular myelin, and they are decorated by surfactant protein B and C. Okay, good. Now, which antibody is this? Again, simple question. Which is this antibody? 1, 2, 3, 5. IgA, IgG, IgM, or IgE. Yes, very good. Everyone knows pentamer. IgM are pentamer, wonderful. And immunity, Ig, hypersensitivity, Ig, allergy, and all those things, sneezing, coughing, and all. IgA is produced in the secretion, which comes in the primary infection. It is IgM. In the secondary, it is IgG. Okay, good. Now, one more. There are a few more questions. Let me. Only 5 questions more. I will take only 10 minutes more. Now, please tell me this question fast. This we have done with. Okay, tell me. Maximum water absorption occur from which part of nephron? Maximum water absorption occur from which part of the nephron? A, B, C or D? A is your PCT, you can see. B is your Henle, C is your ascending Henle, and D is your collecting duct. Maximum water absorption is from where? Very good, excellent. Answer is PCT. How much? 67% of water. Two-third of the water. This is obligatory or facultative? This type of water absorption is called as obligatory water absorption or facultative. क्या बोलते हैं इसको? We say obligatory water absorption or facultative? It is called, it is always. So it is obligatory. It is always, so it is obligatory water absorption. Facultative is in the presence of ADH. It is from collecting duct. It is from collecting duct. The water absorption which is from PCT is obligatory irrespective of ADH. ADH is present or ADH is not present. Maximum water absorption is from PCT. But the few amount of water that is absorbed from collecting duct in the presence of ADH is called as facultative. Okay. Next question. Sodium, potassium and chloride co-transporter are located in. Just now I have discussed. See, every year they ask same question. Believe me. Same topic at least. Where is NCC? NKCC. Sodium, potassium, chloride channel. In the previous paper I have discussed. Na? And again they are asking the same question. PCT, DCT, thick ascending lobe of Henle or collecting duct. What is the answer? Very good. Everyone is correct. TAL. TL mat bhulna, it's very very important. Thick ascending loop of Henle has NKCC. Mutation causes Bartter syndrome, and the drug which block this is called as loop diuretic. It is loop diuretic. Very good. Identify the event taking place in the intestine. Can you identify what is happening? Is it peristalsis, segmentation, or passive diffusion, or basic electric rhythm? What is this happening? Just see the image, then I will give you option. Just see this image. Mixing and churning is going on. Contraction, contraction, and contraction. What is the answer? Is it peristalsis? Is it segmental movement? Is it basal electric rhythm? Or what? Mass movement or... Have seen the image? Okay, come to the diagram. Answer: peristalsis, segmentation, passive diffusion or basic electric rhythm. Very good. Segmentation. So what is the difference in peristalsis? If you remember, doctor, we know what happened in peristalsis. What happened in peristalsis, doctor? There is a bolus. There is a bolus. There are myenteric ascending neuron. There are myenteric ascending neuron. And what do they release? क्या release करते हैं? They release acetylcholine. Very very important topic. Acetylcholine and substance P. And what does they do? They cause contraction behind the bolus. They cause contraction behind the bolus. And the descending neuron, they release nitric oxide and vasointestinal polypeptide which cause relaxation. So, contraction, relaxation, contraction, relaxation. This is called as peristalsis. This is called as peristalsis. So in the peristalsis there is contraction, there is relaxation, contraction, relaxation. This is peristalsis. In the segmental movement there is only contraction and contraction. There is no relaxation. Segmental movement is for mixing and churning of the food. But peristalsis is for motility of the food. Migratory motor complex is for what? When we are having empty stomach, M cell release motilin hormone that clear your GIT. That just clear your GIT. Next question, which of the following hormones will regulate release of prolactin from the anterior pituitary? Which of the following hormone regulate prolactin from anterior pituitary? Normally they say no, there is no hormone that release prolactin, but there is a hormone. Which is that hormone? Corticotropin releasing hormone, gonadotropin releasing hormone, follicle stimulatory hormone, or thyrotropin releasing hormone. I have discussed in the first chapter of hormone. If you have taken my notes, okay, very good. Most of you are correct. So thyrotropin releasing hormone not only stimulate TSH but also prolactin stimulatory hormone. Okay, it also stimulates prolactin. I mean, it is also type of prolactin stimulatory hormone because it also stimulates prolactin. That is why in hypothyroid patient, okay, it will increase TSH, it will also increase TRH, and that will increase prolactin. That causes an ovulation and that causes menstrual problem. This is your Viva question, your MCQ question, your concept based topic, that why there is menstrual problem in hypothyroid. भाई हाइपोथायराइड का मेंस्ट्रुअल प्रॉब्लम से क्या मतलब है? इन हाइपोथायराइड T3 T4 are less, it will increase TSH, which will increase TRH, and TRH will increase prolactin also. And prolactin, I have told you, it decreases ovulation, it inhibits ovulation. Okay, next question. Only 3 questions are left. Which of the following is correct about jugular venous pressure? Which question is correct about, which of the following is correct about JVP? Which is correct about JVP? Measured from GP sternum, V waves occur in isovolumetric contraction, rise with deep inspiration, Y descent occur in rapid ventricular filling. What is the correct answer? Dr. Shailesh, very good. Very good. Answer is D. See, there are 3 wave. A wave, sorry. There are 3 wave. A wave, C wave, and V wave. Jugular venous pressure. A wave stand for what? A stand for atrial contraction. C stand for what? C stand for when cusp bulge into the atria during isovolumetric contraction. And V stand for venous return. V stand for venous return during isovolumetric relaxation. During isovolumetric relaxation. Then doctor, you have X descent and Y descent. X descent and Y descent. X is for what? When there is ventricular, ventricles will fill the aorta or the pulmonary artery. Yes. So it is because of ventricular ejection. And Y descent is because of ventricular filling. When atria relax, ventricle fill. So Y is because of ventricular filling. So all of you are correct by selecting answer D. Very good. Now the last question, a 25-year-old patient after head trauma presented to the emergency room. On neurological examination, he was found to have normal handwriting and could copy shape of the object but could not speak. So which type of aphasia is this? Which type of aphasia is this? He understand, he copy also, but he cannot speak. What is the answer? This is the last question for the day. Wernicke's aphasia, Broca's aphasia, conducting aphasia. Broca's aphasia. Okay. So let me discuss in just 2 minutes. Broca's area is located where? What is the location of Broca's area? What is the location of Broca's area? Broca's area is located where? Inferior frontal gyrus. And this is the area which is important for word formation. It is important for what? Word formation. And if this area is not working properly, fluency will be lost. Fluency will be lost. It is why it is called as non-fluent aphasia. Patient is non-fluent. He cannot speak. Understand everything, but speak nothing. समझेगा सब कुछ. Because Wernicke's area is okay. He understands everything, but cannot speak. It is called as Broca's aphasia, doctor. Second is Wernicke's aphasia. What is the location of Wernicke's area? What is the location of Wernicke's area? Superior temporal gyrus, and the function is understanding, comprehension. It is the dictionary in your brain. Understanding, comprehension. It is your comprehension. Comprehension. It is for your understanding. And if there is Wernicke's aphasia, he or she can speak fluently but cannot understand anything. Okay, so understanding is gone, but fluency is maintained. So this is called as fluent aphasia. Fluent aphasia. Okay, he can speak fluently but no comprehension. He cannot understand what you are saying. No understanding. No understanding, no comprehension. Now the third is anomic aphasia. The most common is called as anomic aphasia. What is the problem here? Who will tell me? What is the problem with anomic aphasia? Anomic aphasia is due to lesion of what? Yes, Sahil? Where is the lesion? Yes, Aditya Gupta? Awesome Blossom, yes, anyone? Where is the lesion? Lesion कहाँ है? Angular gyrus. Lesion, very good. Lesion is at the level of angular gyrus. And he can, see, whenever I see something, it get to my visual cortex, then to the angular gyrus, and then to the Wernicke's area for understanding. If you are seeing me, it is going to your retina, then your cortex, then angular gyrus, and then to Wernicke's area. Wernicke's area is a decoding area, where decoding is happening. Whenever I say something, it goes to your temporal cortex, then goes to Wernicke's area for understanding. If I am speaking English, you understand. If I speak Hindi, you can understand. If I suppose I speak some other language, you don't understand because Wernicke's area does not have dictionary for that. Okay. So if there is lesion of angular gyrus, understanding of oral language will be okay, but written language cannot be understood. Written language, because if I write something, it goes to your eyes, to the angular gyrus, to the Wernicke's area, but angular gyrus is not working properly. If I say stand up, you follow the command. But if I write something, you say, what is this? I don't understand. If I say this is an apple, okay, I say, what is this? You will see this is an apple, but you cannot name it, because problem is with the vision. You can see it, it can go to the cortex, but not to the Wernicke's area. So you cannot name something. It is called as anomic aphasia. The most common variety is anomic aphasia. You can understand everything, but you cannot name. It is called as anomic aphasia. So I will not take much of your time. This is it for today. And if you want, just tell me if you want any other class for any other topic you want, or any other previous year MCQ you want. Okay, or just give me all MCQ which you have doubt. I will collect those MCQ and I will make a separate session for that, or any topic you want. So this is for today's session. I hope there is no doubt in this. And sorry for my bad throat today. I was not feeling good. So thanks everyone. I am going to stop the streaming. Image based you want, Dr. Sailesh? Okay. Okay, well done. So thank you, awesome blossom. Everyone, thanks a lot. So just you want a level high or okay. One clinical question, so I will make one more session. Sure. Thank you. Thanks a lot. Thank you for joining. Thank you for bearing me. Okay, bye. Take care. And for any doubt, you are most welcome. Just drop the question in the Telegram group. I will try to answer.